you wanna. So thank you all today for joining us on our discussion on Sinai Community Health Survey 2.0 and our approach leveraging the survey to translate data to knowledge with community. Today, we're going to cover a brief overview of the survey's development and aims, and then talk a bit about our approach to community-driven knowledge creation, and talk about some of our findings and how this approach really elevates community-driven priorities in our findings from the survey. Then we're also going to talk a little bit about our dissemination, and then open it up at the end for a little bit of a longer Q&A panel. If you have questions along the way, please put them in the chat. We will keep track of them and we can address them during the Q&A panel at the end. I am so honored to have these lovely, wonderful, brilliant colleagues with me today. They will each introduce themselves more formally as they speak throughout, but briefly we have Melissa Crutchfield from Lawndale Christian Health Center, Juana Ballesteros from the Illinois Department of Public Health, Kristen Meyer from the City of Evanston's Department of Health and Human Services, and Dr. Jana Herstick from the University of Michigan. I'm Pam Resch, and I'm currently the Director of Health Equity and Assessment Research at SUHI. And also, before we get started and talk about the survey, we want to take a moment to acknowledge and give thanks to the residents on Chicago's west and southwest sides who partnered with us in order to develop, administer, and disseminate the survey's findings. It is with you who this work was produced in partnership and solidarity. With that, I'm going to hand it over to Melissa to talk about the survey's development and aims.
Hi, welcome everyone. I'm Melissa Crutchfield and I do work for Lawndale Christian Health Center as the Director of Hospitality here. I also am co-founder of a business called Fit Together, a holistic wellness company. I live on the west side of Chicago. I'm a mother of 3 and I raise my children here. I'm also a part of the Best Babies Zone Committee in East Garfield Park and UIC School of Public Health, their Greater Lawndale Healthy Work project. So I just really deeply care about the people on the west side and love to dig deep to find, ways to help them access health and wellness. Go ahead and flip the slide. So the purpose of the 2.0 survey was really threefold. The first was to document the health status of Chicago communities. We definitely already had information on births, deaths, hospitalizations, and things of that nature. But what we didn't have was disease prevalence, health behaviors, and social factors readily available at that time. So things, the variables that we more and more are seeing affect health. So the second part was to collect and understand these social factors, things like food insecurity, incarceration, and their relationship to health outcomes. So we made sure that the survey didn't just ask about health behaviors or healthcare access, which we know are only part of the big picture and partly in explaining the inequities we see in health outcomes. We made sure to dig deeper into the social and economic factors, which some models estimate predict up to 40% of the inequities we see in health outcomes, more than behavior, healthcare access, or the environment. We'll cover some of these findings today. The final reason was we wanted to translate findings to address health inequities. For example, the 2002 Sinai survey data informed health interventions within SUHI, such as smoking cessation and community health worker programs. And they were always also used in survey communities, such as the Diabetes Empowerment Center in Humboldt Park. So we wanted to conduct the follow-up after 2002 survey to see how things have changed and get updated measures of community health statuses. So 10 years or recollecting data shows us, how communities have changed, how the overall health of Chicago has changed. As we know, Chicago gentrifies and changes quickly, so we wanted to see where everyone was at. Data was collected from March 2015 through September 2016. It was quite the feat. It took a long time, but it was because they were face-to-face interviews. They were in-depth interviews. They really got at not just those, check the box answers, but we dug a lot deeper. And they were conducted in both English and Spanish, so the development took a while. And when we say like the wide breadth of topics, these questions range from diabetes to, do you feel safe walking in your neighborhood at night? So we really touched on a lot of different topics. There were over 500 questions on 40 plus health and wellness topics, if that gives you a good idea of the size. And so it was a huge investment for our interviewers, but also for the people we interviewed. They had to take the large amount of time to really share their stories with us. And as Pam said earlier, we're just so thankful for the participation and the solidarity that we found in these neighborhoods. Altogether, about 1,500 adult and 400 children were interviewed. Okay, so our survey included several communities on the west and southwest sides of Chicago, some of which have been served by Sinai for almost 100 years. These communities were selected because they were in Sinai's primary service area. You can take a look at the map and see the neighborhoods. But because we also wanted to look at racial and ethnic differences, we also pulled in Humboldt Park, Westtown, Hermosa, and Norwood Park, so we could put data side by side. And we'll look at some of that data later on. We surveyed in such a way that the data is representative of entire communities, with the exception of Westtown, which is representative of the area west of Western Avenue. So, to get good data, you have to touch a certain percentage of the population. And so we made sure to do that. So everybody just take a look at this slide. It's, for me, it's kind of hard to look at. I serve in North Lawndale, so $21,000 a year is a median household income. So, and this speaks to a lot of us deeply. Herein lies a lot of the inequity. But the communities surveyed overall had low medium household incomes, with all but one falling below the Chicago and US levels, with some having median household incomes as low as $21,000 per year. It is important to note that Norwood Park, the one community that had a higher median income, was our only predominantly non-Latinx white comparison community that was as economically similar to our target communities as we could identify at that time. I guess what this shows is just this underlining deep-seated economic inequity between Black, brown, and white communities in Chicago. If this is the closest we could come, it says something about where we're at, right? It's important to keep in mind that these root cause economic inequities when we talk about well-being and our survey results. Go ahead and flip to the next slide. Oh, look at us. This is so long ago. Look at this beautiful group of people. These people started off as strangers, and now I call them friends and colleagues. They are like family from neighborhoods from all over the city. We assembled this community advisory committee with residents from all of the communities, and they were instrumental in every step of the survey process, from questionnaire development to community dissemination planning. And when I say questionnaire development, going through every single question, and even just like saying, hey, you can't talk to people like that in this neighborhood, or this would not be taken. That's not even what that word means to us. So it was like going through a haystack looking for this magic needle, right? And we did that for every question. And we added questions and we took things away and we said, that's not relevant anymore. So it was just a beautiful process where respect was shown to everyone. Our voices were heard. The people from the community definitely had the last say, which was very important. We were blessed with a team from SUHI that definitely listened and were humble enough to accept that the community residents were the experts in the situation. And and that's why we walked out of it feeling the way we do. So we had at least 2 reps from each survey community area, and we assessed cultural appropriateness, relevance of questions, and we started with over 800 questions for the survey, and we worked through and identified the final set. The CAC also oversaw the administration of the survey, so hiring of people to do the interviewing, all of that. We provided feedback and context on key findings, identified key topics to prioritize sharing broadly with communities and beyond. We led community level dissemination and planning. Now, the beautiful thing was we had the final say. So if there was data that showed our neighborhoods in a negative light or was very stereotyped, yes, we still put it on the website, but we didn't push it because we knew that like our goal was to do this in a way that reflected the goodness and the humanity of each person involved, period. And so, yeah, that's what we did. And to this day, we still have a community advisory committee that still counsels, but this was a really special group of people.
Hi there, I'm Kristen Meyer, and I now work at the Evanston Health Department as their community health specialist. But from 2015 to 2020, I served as the community engagement manager with SUHI and coordinated the community advisory committee. So worked very closely with Melissa and the rest of the community on this. And I want to talk a little bit today about some of the way that we did community-driven knowledge creation and dissemination. So as a community-based research institute, SUHI thinks a lot about the right way to do responsible research that produces knowledge that really drives change, that doesn't just sit on a shelf. And too often research, even when it's produced with good intent, really just creates data for its own sake or doesn't really move the needle on improving health and quality of life, which is the whole reason that we collect this data. And oftentimes researchers that are collecting this data don't really have the tools to know exactly how to get this data out to the right audiences that can really act on it. And conventional kind of techniques for disseminating information can have limited audiences, more academic or less really influencing and reaching the people who make decisions or community members themselves. And we know that there's growing awareness among researchers and among communities that we really need to do a better job of sharing data and particularly sharing data back with the communities where it originated. But sometimes that's treated as an afterthought among researchers about, once the research is done, then they think about, oh, how do we share this back with the community in a simple presentation or something like that, rather than involving people at every step of the way. So we wanted to make sure that we didn't make that same mistake. So when we think of research and dissemination, we think of kind of creating and sharing knowledge in partnership with the community, just like Melissa talked about, so that it was truly a collaborative effort every step of the way, collecting that data in partnership, and then taking that data and really contextualizing it within that lived experience and wisdom of community members to turn that data into meaningful and usable knowledge that can really improve people's health and quality of life. And so we know that research that is created and shared by, for, and with community members is so much more powerful in producing good information and in driving the change that we all want to see. One of the things that we all loved about this effort so much was that it really was a community-driven process at every step of the way. So everywhere from conceptualization to dissemination, just like Melissa talked about, everywhere from picking the questions to determining how information was shared out in what kind of packaging and messaging, what information to make sure that we're contextualizing appropriately, that kind of thing. And doing this research in very close partnership at every step of the way with community members is critical for two reasons. First and foremost, it respects the right of our community members to own their stories, to envision their own future, to author their own narrative. But secondly, it just produces better research and better information. So our community members could tell us when something just wouldn't, a question wouldn't work for the community members, or when they might interpret a question differently. They could help provide context so that we're making sure that that data that we're putting out is reflecting appropriate conclusions. And then lastly, and most importantly, our community members who live and work in these communities, raise children there, have the most skin in the game, and are going to be the most invested in making sure that this research is driving that change that we're all looking for. And then one of the ways that we engaged community voice beyond our community advisory committee was through the use of community forums, where we gathered community residents. And so this was a really great opportunity to get community input, again, contextualizing our findings and making sure that they resonated with community members and were situated kind of within that lived experience and wisdom of our community members. So in our community forums, we hosted dialogues in a roundtable format, where our community health workers presented a little bit of the survey data, and then just invited community members to give their feedback in what they saw in the numbers, and kind of what caveats they would present in understanding what the data meant. And one thing that was really important in this process was inviting community members to push back when the data didn't seem to reflect their experience, because that just helped us understand the data that much more, and then the possible actions that could follow to improve on the health and quality of life of our community members.
Thanks, Kristen. So I am going to, this is Pam again. Juana, Jana, and myself are going to go through some of the findings from the survey and demonstrate some of these different pieces in action that Kristen and Melissa highlighted, and how we really can produce more contextualized and deeper understanding of health within the communities we surveyed on the west and southwest sides. So the first, I'm going to start with an outcome, like a health outcome. We're going to look at PTSD, or post-traumatic stress disorder. Before getting into any of these findings, I do want to reiterate to everyone that this was collected from 2015 to 2016, so does not account for what we is likely an exacerbation of what we found due to the past year of the pandemic and its onslaught of economic disaster it has caused many of the communities on the west and southwest sides. But back when we did collect this, we looked at PTSD in part because it has a huge burden in its own right on communities, but is also a path to physical and chronic illness such as diabetes. And this example shows the depth of our survey. So we asked about PTSD in a couple of ways. The first was that we asked individuals and adults if they had ever been told by a healthcare professional that they had PTSD, to ascertain the levels of diagnosed PTSD. And here are the findings here across communities. So to orient you all to these slides, because there'll be several graphs that look like this, the communities that we surveyed were on the left side, and you can see the prevalence of the different indicators, in this case, diagnosed PTSD, on the right side. Suppressed is where we just didn't have enough data to make a confident estimate. So we were being responsible about not oversharing when we didn't have quite enough data. So what we can see here is that this is a civilian population, and we see quite high levels of diagnosed PTSD, with about 1 in 10 adults having diagnosed PTSD in 3 communities. Now, the other thing we know about the communities we serve on the west and southwest sides is that there are various barriers to healthcare, and particularly to mental health care. So, in addition to asking about diagnosed PTSD, we asked a series of validated questions about current PTSD symptoms in the past month. And you can see the results from those questions here. Overall, what we saw is that in a couple of our communities, about 1 in 4 adults screened positive for current PTSD symptoms. And even though we see some of the same communities with the highest levels of burden in this chart as we did in the diagnosed chart, what we see here is the higher levels of burden. So we're seeing like 2 to 3 times the level of burden when we're looking at current symptoms versus just looking at that diagnosed indicator. So I'm going to turn it over to Juana, who's going to talk a little bit about what we heard in our forums in relation to some of this data around PTSD and also depression, which I did not highlight here.
Hi, can you hear me? Perfect. Yes. Hi, everyone. My name is Juana Ballesteros, and I just want to say that I am very honored and humbled to be here. My partnership with SUHI started 13, 14 years ago when I was like 20-something-year-old running a health coalition in Humboldt Park. And I was so honored and blessed to have met Steve Whitman, Dr. Steve Whitman, the founder of SUHI. And I think he is joining us today and very proud of what has become of his vision. And he himself was just like one of the best mentors this 20-something-year-old could have ever asked for. And actually, the first community health survey was actually the impetus for the founding of the Greater Humboldt Park Community Wellness, which I was the executive director for 4 years, and really shed light on health disparities, huge health disparities in the Humboldt Park community, in particular the Puerto Rican residents of the community. And I'm happy to say, 14 years later, I'm still able to partner with SUHI on so many different initiatives. So I'm so honored to be here. So post-traumatic stress disorder, as part of the community forums that were mentioned earlier that were conducted to share the findings with different community residents and stakeholders, we shared select results that were selected by the Community Advisory Committee, of which I was a part of that advisory committee. And we had discussions in a roundtable format. PTSD and other mental health issues was definitely a topic of discussion at many of these forums. While we do not have all of our notes tabulated, this highlights some of the thoughts of community members in relation to mental health issues. And I ask that you take the time to read that slide and some of the feedback. Many community members were not surprised by the rates we reported due to the various hardships individuals and their communities face on a daily basis. Community members also alluded to the stigma surrounding mental health issues and the reluctance to seek help. Within some communities, there was discussion about the inadequacy of services available, even if someone was diagnosed. And I think, my initial thought when I first saw this slide is, oh, PTSD, that's a very, very strong word, right? And like it was mentioned earlier, these are civilians, right? These are people that were not involved in war or any military role. But it really just lets us know that there are people, neighbors, friends and family who have this accumulation of stress, right? Because of their daily lives and daily struggles that have led to chronic stress, which then could lead to what we mentioned, diabetes, high blood pressure, and other issues. So I'll turn it over to you.
Thank you, Anna. And so now I'll talk a little bit about some of the upstream factors that we also looked at in the survey to really understand those the root inequities that produce the health inequities, which we also know are further rooted in racist policies that are not only historic, but perpetuated through today. And one of the key things we looked at was household food insecurity. And I want to underline that food insecurity measures access to affordable and nutritious food. So that's what we're looking at here. And when we surveyed our communities, we found here the results of household food insecurity in the past year. We found quite high rates that were well above the US rate of 13%, within some communities rates reaching 1 out of 2 households in the past year being food insecure at some point. We also looked at this by race and ethnicity as markers of historic and perpetuated inequities and racist policies and systems. And here we saw that non-Latinx Black families and households were about 3 times as likely as white households to experience food insecurity in the past year. We also saw quite high rates among families of Puerto Rican and Mexican descent. In addition, when we looked at our child data, we also, so I want to note that the child data, we talked to caregivers of children aged 12 and under. And so this is representing among households with young children aged 12 and under, the percent that screened positive for child food insecurity in the past year. And what we found here is that about 1 out of 3 households with young children in several of our communities had instances where the children in the household didn't have access to food, or also very importantly to nutritious food in the past year. So this is another space where we've gathered this information, as defined in the survey and guided by our Community Advisory Council. But we also wanted to talk to communities to understand root causes and how we can start moving the needle on this. And so Juana's going to talk a little bit about some of the similar and different findings we had during our forums to provide context to this data.
Thanks, Pam. Another way our forums demonstrate the importance of community insights and sense making was highlighting differences in the root causes of similar challenges like food insecurity. One striking example of this is our discussions of food insecurity, which impact both North Lawndale and Little Village, or South Lawndale, 2 neighborhoods located right next to each other on the west side. Next slide, please. Demographically, they look quite different on paper. North Lawndale is predominantly Black or African American. South Lawndale or Little Village is predominantly people of Mexican descent with many immigrants. And I myself am a daughter of Little Village and raised my daughter in Little Village. Next slide, please. As both communities face low median incomes, it was not surprising when our survey revealed in both communities high proportions of households that were food insecure in the last year. Next slide, please. Considering this proximity of these 2 communities, North Lawndale and Little Village, a hospital like Mount Sinai may think that one approach could be used across communities to address this need. At the forums, we heard from both communities that stagnant wages, a lack of employment opportunities, and the high cost of healthy foods were contributors to food insecurity. But as our forum discussions continued, we started to see some very distinct concerns and contexts in the 2 neighborhoods. In North Lawndale, forum attendees discussed the fact that the community is a physical food desert. They discussed how much money and time it took to get somewhere where they could access fresh fruits and vegetables. The discussion was different in Little Village, which has a large immigrant population. There, people discussed that there are resources available to help address food insecurity, but residents brought up the different barriers to accessing those resources. In particular, due to the political climate, immigration status, community members were concerned about seeking food assistance because of those concerns, due to the fact that unfortunately many food pantries do ask for ID cards. And so you can imagine for individuals who are mixed status family, undocumented, that will definitely pose as a barrier for folks accessing food when they really need it. So they obviously don't feel comfortable accessing these resources. We actually collected numbers on accessing emergency food and saw these background issues play out. These distinctions are important because they demonstrate why one type of program on the north side of Ogden may not work on the south side of Ogden. If we really want to maximize impact, we need to be cognizant of these different pathways to food insecurity while still accounting for the similar root causes of economic inequities. This is true for so many things, and the approach to our survey makes it easier to grapple with and understand these differences.
Great. So I am going to move. I'm gonna speed through this a little bit. So please ask questions if you have more at the end, just to give enough time for the panel at the end. But I did want to highlight that we also looked in the survey, and this is kind of another angle of the survey. We looked at child healthcare access and use. And really overall, looking at healthcare access and use, we found that across communities, many children had a usual place to get healthcare. They had a well child visit in the past year. Many were insured. Majority were publicly insured. And we didn't see a lot of differences across communities in regards to kind of these base healthcare access and use factors. However, we did see variation in the utilization of healthcare across communities. And I'm just going to cover one item here, which was related to accessing the flu vaccine in the past year. So this is the percentage of caregivers who reported that their child age 12 or under received a flu vaccine in the past year. Now, we didn't have this data tabulated for the forums. However, we did discuss it on our CAC. And the group very rightfully pointed out, this could be the way we ask this question. Parents or caregivers might not know that a child got a vaccine at school. No one knows what happens while child visits. Doctors are in and out of the room. So there could be some of that. But the group also highlighted that there could be some level of mistrust or vaccine hesitancy across communities. And so that leads into a little bit of some other deep dives we did into the survey findings, because in addition to asking about healthcare use, we asked caregivers about their satisfaction with child healthcare providers. And we did this in part because satisfaction of the caregiver is incredibly important to children getting preventive care and being healthier overall. And so it's important that caregivers want to take their children to the doctor and feel that they can make shared decisions with the healthcare providers. I'm going to show a little bit of what we found here. It's not everything, but it'll give you a little bit of view of some of the depths and nuance that's within the survey. So the first thing, we asked caregivers if their child's doctor always spoke their preferred language in the past year. And looking at this by group, we found that caregivers of Latinx children were less likely to report that their child's doctor always spoke their preferred language. And then we actually looked at subgroups among Latinx caregivers and found that caregivers of children of Mexican descent were much less likely to report that their doctor always spoke their preferred language. Beyond this, we also looked at various measures of overall satisfaction. And here we see it's the percent of caregivers who reported that they were extremely satisfied with their child's overall healthcare in the past year. Before we talk about differences, I want to highlight none of these rates are great. So it's, we're looking at best 1 out of 5 caregivers were extremely satisfied. But we did see some differences in groups, again, with caregivers of Latinx children being less likely to report extreme satisfaction, and then really caregivers of children of Mexican descent much less likely than caregivers of children of Puerto Rican descent to report extreme satisfaction with healthcare. So particularly as we're thinking about COVID and the eventual rollout of the vaccine more broadly, I think it's important that we understand these underlying feelings and perceptions among caregivers. We don't have the data to really explain in more detail, but one thing that it highlights that I know SUHI, Sinai Chicago, and many of you on this call are working on is that diversification of the healthcare workforce at all levels to ensure that our healthcare workers reflect our communities that they work in. So I'm going to stop there and hand it over to Jana, who will speak about some of her work with the Sinai survey.
Thanks, Pam. Hi, everyone. I'm Jana Hirschtick, and I'm currently a research faculty member at the University of Michigan. But before this, I was an epidemiologist at SUHI for 8 years and really heavily involved in Sinai Survey 2.0. So all of this work is very near and dear to my heart, and I'm very happy to be here with everyone today. I'd just like to spend a few minutes describing an analysis I conducted to better understand exposure to police use of force in the surveyed Chicago communities using Sinai Survey 2.0. So I wanted to understand what factors are associated with experiencing police threat or use of force, in addition to race, which is a very well-established risk factor. So I conceptualized 4 different kind of buckets of potential risk factors. The first is personal characteristics, and I looked at race, ethnicity, age, sexual orientation, and immigrant generation. Then within neighborhood environment, I was able to look at crime rates, a hardship index, and racial segregation. Within social status, can you guys see me? Okay, sorry, I'm getting some messages about my video. Hopefully everyone can see me. Within social status and behaviors, I had education and employment, ever homelessness, prior criminal conviction, drug and alcohol use, being in a physical fight in the past year, and a history of mental illness diagnosis. And then we had a number of questions about interactions with the police. So that included history of police stops and stop legitimacy. So I pulled stop legitimacy out into the middle of the slide here because it's really important. And I also wanted to share with everyone how we measured it. So we asked respondents during their most recent stop, would the police say that you had a legitimate reason for stopping you? And then I looked at all of these factors as potential predictors of threat or use of police force during their most recent stop. So for that, we asked, did the police use or threaten to use force against you for any reason? I'm just going to very briefly touch on the analysis, but I'm happy to answer questions later. I restricted it to our predominant racial and ethnic groups in the survey, which were Puerto Rican, Mexican, non-Hispanic Black, and non-Hispanic white respondents. And I also restricted it to people with at least 1 lifetime police stop, so I could separate out the risk of being stopped by the police from the risk of experiencing threat or use of force among those who were stopped. I ran separate logistic regression models, so to predict the odds of experiencing threat or use of force, and I ran it separately for men and women because I thought that there might be different predictors for men and women. And what I did was I looked at each of these buckets of potential predictors one by one to see which factors were significantly associated with the outcome within each bucket, and then I added them to a fully adjusted model. So there were several key predictors of threat or use of force that emerged for men. And the first, which is consistent with a large body of prior literature, is race ethnicity. Compared to non-Hispanic white men, Puerto Rican men had nearly 5 times increased odds of reporting threat or use of force during their most recent stop. Men of Mexican descent had 6 times increased odds, and non-Hispanic Black men had 9 times increased odds. And these associations remained strong and significant after accounting for neighborhood factors, social status and behaviors, and other measures of police encounters. Within social status and behaviors, being unemployed, in a physical fight in the past year, and reporting ever homelessness were all associated with significantly increased odds of threat or use of force for men. In the fully adjusted models that had all of these factors, men who were ever homeless had nearly 4 times increased odds of threat or use of force during their most recent stop. And then importantly, if you look to the middle of the slide, men reporting an illegitimate reason for their most recent stop had 3.6 times increased odds of experiencing threat or use of force during that stop. And that's after accounting for all of these other factors. So stop legitimacy emerged as a very important potential predictor of experiencing threat or use of police force. A slightly different set of predictors emerged for women. Race was an important predictor before adjusting for other personal characteristics. So race certainly matters for both men and women. In the model adjusted for other personal characteristics, sexual orientation was a very important predictor for women. So women, LGBTQ women had 8 times increased odds of threat or use of force compared to straight women, after accounting for both race and age. Within social status and behaviors, women with a prior criminal conviction or reporting ever homelessness had increased odds of threat or use of force, after accounting for personal characteristics and neighborhood environment. And then similar to men, women reporting an illegitimate reason for their most recent police stop had nearly 6 times increased odds of reporting threat or use of force during that stop. So stop legitimacy was a very important factor for both men and women. So I'd just like to reiterate a few of these key takeaways. And the first is that race continues to be a master status for experiencing aggressive policing. This was strongly associated with threat or use of force for men, and was also associated for women before adjusting for other factors. We also really need to better document and understand the association between LGBTQ status and aggressive policing, to understand the burden of aggressive policing among this population. I know I'd done this analysis a few years ago, and at the time that we were looking at this, there was not a ton of literature on this subject, but it's clearly an issue, and so we really need to be doing a better job of documenting this issue for the LGBTQ community. In our sample, ever homelessness was a very important factor for both men and women. And prior research has shown that homeless individuals have reported heightened police scrutiny due to their social status. And this may also be driven by unreasonable arrest quotas. So even though this was a measure of ever homelessness, and we don't know the timing of homelessness versus the timing of their most recent police stop, there's clearly something about this ever homeless population that is potentially putting them at increased risk of poor interactions with the police. And then lastly, stop legitimacy matters. It was strongly associated with police threat or use of force in our sample. Both men and women reporting an illegitimate stop had increased odds of threat or use of force during that stop. And this is consistent with prior qualitative research that shows that individuals who are stopped without reason may put themselves at increased risk by questioning police actions. And this has really important implications for policies like stop and frisk. So just to quote a few stats, in New York City, kind of the epicenter of what we think of in terms of stop and frisk, nearly 90% of police stops were unwarranted during the height of their stop and frisk program between 2002 and 2016. So nearly all of them, 90%, right, were unwarranted. The ACLU did an analysis comparing Chicago's stop and frisk rate to that of New York City at the height of their stop and frisk, and the Chicago rate of stop and frisk was more than 4 times greater that of New York City. So stop and frisk has many implications, but one that may not have been previously documented is that it may put people at increased risk for experiencing police use of force. So to close, I just want to touch on the importance of recognizing police violence as a public health issue. The public health community is finally starting to do this, which is critical. Most of this work to date has focused on police violence as an important health exposure, linking it to poor physical and mental health outcomes. And it is really key that we document those things. But police violence is also a health outcome in and of itself, just as are other forms of injury and violence. So we really need to fully quantify police violence as both a health exposure and a health outcome to estimate the public health impact. So that is all I have today. I just briefly wanted to touch on this, but I'm happy to answer any questions, and I'm going to turn it back over to Kristen now.
Great, thank you, Jana. So as you can see from getting just kind of a snapshot of some of the data that we collected, it's very important to share out and also to act on. And we wanted to also make sure that when we were sharing out that information, we were doing it responsibly in a way that honors the context around it and in a way that drives action to improve health and well-being. So we'll talk a little bit about our dissemination approach for how we shared this out. So our dissemination methodology was guided by John Lavis and colleagues' framework for knowledge transfer and his principles of community engaged research. So we kind of asked ourselves questions within each of these buckets. Under message, what stories were most important to share? What data coming out of this process is most important to communicate? For audience, who needs to hear this information? Thinking much more broadly than like the usual suspects of end users of research. So not just the academic community, but how do we get this in the hands of policymakers? How do we give it back to the community so they can use it in whatever way they see fit? How can we make sure that this information goes to our nonprofit community so they can use this data to better drive program creation? And within each of those audiences, they're going to want different kinds of information. So really thinking about what information was most appropriate and important to give to each of these stakeholders, and what would be the most user-friendly format for each of those audiences. And then finally, for the impact, kind of how we could measure whether we were doing a good job getting that information out to all of these different stakeholders. So just as a couple examples of the way that we worked through this, as we've talked about, one of our most important stakeholders were our community members. And so thinking about, the messages that they needed to receive and the mechanisms, our community advisory committee thought it was most important that they get information about some of the mental health conditions that are very prominent, and also to destigmatize that just by knowing that it is very prominent, and also to give resources to community members. So one of the things that we heard so strongly from our community advisory committee is that you shouldn't tell people about a problem if you can't propose a solution. You need to have resources backing that up, and tell people where to go if they're experiencing something like PTSD. And so one of the things that we did was make sure to put local resources on our information for community members. Here's a few examples of the dissemination products that we created for our different audiences. So the first one, the Community Health Counts, that was a product that we created kind of with our academic stakeholders in mind, with our researchers, our data analysts, our policymakers. That was an important source of data for our community organizations who were using this data to populate some grant applications to really show burden of need in their community members, so that they could get funding to create programs to respond to it. We've got our infographics to the right of that, which were one-page handouts that were put kind of all over the community in churches, clinics, that kind of thing. They were, one page, Spanish on one side, English on the other side, really easy to photocopy and get the word out about health issues and about kind of what community members can do about them. Another thing that we created is on the bottom, community health profiles that kind of go through each community and provide a snapshot of health in that community and all of the factors, the social and economic factors that influence health outcomes, and kind of outlining an argument for really focusing on those social and economic drivers of health. And again, all of this was created in very, very close partnership with our community advisory committee. And they were so helpful in helping us tailor all of these messages, design, community-friendly information, and really honoring, again, the dignity of community, and making sure that in all of our information, we really emphasize that communities are more than just these numbers that we collected, right? And they have rich histories and cultures. And so one of the ways that we integrated that idea was through the community health profiles on the bottom. Before we presented any data about communities, we took a little bit of space to honor their ethnic heritage, to talk about kind of points of community pride, landmarks in the community, to again remind people that again, community members are more than just the things that they've been through, and that there is more that creates identity than the survey data.
So I want to open it up. For any questions, please put it in the chat. But I'm going to open it up to our speakers now for a little bit of a panel session for them to provide some additional insights. And I'm going to get started with the first question of, from your experience and work on the Sinai survey, from each of you, what lessons did you learn that you think could be applicable to other researchers and professionals working on Chicago's west and southwest sides to achieve health equity?
Okay, I'll speak to this. So this was one of my first projects in public health and a survey of this kind. And so I learned a ton because I was just starting. But I think one of the things I learned is that there's always a story, and the root causes are often not discussed or looked at. We always want to talk about how many obese kids there are, but there are very few times when we really dig deep and search for solutions on like, why do we not have food in like grocery stores in North Lawndale, so on and so forth. And so I really learned to consistently, not just from you all, but also from the other CAC members, like to dig deeper and learn more about people. And I think the conclusion I came to was, it's in this learning about one another, in these relationships, and we start to build relationships and care about one another, that's where growth and change happens, right? When you learn the story of the people who live in Little Village, and I'm in North Lawndale, and we start to really dig deep and hear their stories, that's where real change radiates from. So I learned a lot about like just digging deeper, always understanding that like people have stories, and they're not, as Kristen said, they're not just some number where, oh yes, they're obese, and so of course they have heart disease, but what is their story, and how did they get to this place, and what systems are built to ensure they stay in this place? So it was really eye-opening to me.
Yeah, I'll just jump in. I think, for me, not just through this process, but just in general with community, based participatory research and that model of doing research, is that I think in research, we're trying to fix something, right? We want to do research to identify a problem and fix it. But I think in that process, we also have to recognize what are the rich assets of your community that you are trying to research, right? And not forget that, even though the health data tells us one thing, many communities don't see themselves in this negative light, right? And they'll let you know, and they don't want this negative reputation for their community, and rightfully so, especially from outsiders. And so I think, that was something I learned a long time ago, is that you should never look at the communities as a deficit, but as, communities with strong leadership, strong assets, and community leaders that are very much committed to the health and wellness of the community. So I think people need to remember that and tap into that.
And just to add to what Melissa and Juana have said, I think one of the things that has really, really stuck out in this process for me is the importance of engaging community wisdom and expertise in using interpretations and contextualization of these findings to drive the so what do we do about these issues? Because if you look at a data point in isolation, being an outsider to the community, and look at like a food insecurity data point, for example, you may conclude that the solution is just adding more food pantries or something like that, when really, if you talk to community members, for example, in a little village, you would understand that there are barriers to accessing those for all different kinds of reasons. And so really working in partnership with community members, not just on the design and development of the research, but also really like understanding how we should act on it appropriately in a way that like honors the truth behind those numbers.
Great. So we have some additional questions, but we are running low on time. So I just want to make sure that no one from the crowd has any questions to ask. And actually, we're quite low on time. We're 2 minutes on time, so I may stop us there. And so we do have one question. So we'll try to keep it under 60 seconds, because I'm going to have someone telling me we got to get off the line. So can you please elaborate on the methods you have used for community engagement to interpret data? Do you use focus groups, interviews, providers, residents? I'd love more information. So Kristen, Melissa, or Juana, or Jana, someone can maybe talk briefly about some of our key methods here. And then Christina, we can also touch base offline to share a more depth of an answer.
Yeah, just given that we're low on time, I know that Dr. Maureen Benjamin's shared out a resource that we produced after this, kind of going through the specifics of how we did community engagement and community engaged dissemination. So I believe she shared the link to that article. So I'd encourage you to check that out.
Great, good. That was a good reminder. Thank you, Kristen. And
obviously the CAC had a big role in that, right?
So I am going to end us here. I want to thank you all for joining. I want to thank these lovely co-presenters and colleagues who I do not get to see as often anymore these days. We miss you at SUHI.